अच्छा इसको एडमिट कर दो यार, ये तो बरोबर है। फिर मैम को मैं एडमिट करा दूंगा, ज्वाइन होगी। हेलो।
Uh, Good evening to the people in India and to different parts of the globe. Be it good morning, good afternoon, and thank you all for joining this webinar. A very, very warm welcome to all the members of audience of this sixth webinar in the series in GAPIO Physiotherapy International Virtual Webinar Series. GAPIO is nothing but Global Association of Physicians of Indian Origin, which is a non-profit organization established in 2011. Padma Vibhushan Dr. Pratap C. Reddy, Chairman of Apollo Hospitals Group, is the founder president of GAPIO with a vision improving healthcare worldwide, with the aim to bring together healthcare professionals of Indian origin in the world on one platform. In these webinars, as I said, it's the sixth one, our endeavor is to bring the expanded scope and the latest advances in the field of physiotherapy to the fraternity globally. Along with us, we are thankful for other multidisciplinary team members, medical professionals to join us and give it a wholesome kind of a platter for the people who are joining. So today's webinar is on importance of renal physiotherapy in the management of chronic kidney disease, a multidisciplinary approach. We all know chronic kidney disease is a major global health issue. 10% of world's population is affected by some form of CKD, which is accounting for 1.2 million deaths annually. And we all know by 2040, CKD will be the fifth leading cause of years of life lost globally. Its major risk factors being diabetes, hypertension, and so on. Many people die prematurely to cardiovascular disease before even reaching kidney failure. And we all know all these patients of CKD, they may require some or the other form of kidney replacement therapy in the form of dialysis or transplantation. So people, those who receive dialysis or they have undergone transplantation, we all know over the years, for them, for their families, for their caregivers, it has a huge socioeconomic impact. We at Indraprastha Apollo Hospital also performed a pilot study on the effect of intradialytic exercise on maximum oxygen consumption and quality of life undergoing hemodialysis in Indian population, a pilot study which has been published in Bulletin of Faculty of Physical Therapy in November 2022. And we found, of course, I was discussing with the doctor a while ago with Dr. Gumbar, and we were discussing it's very important to know what is your patient population when you are working on these patients. But what we found in our study, which was done for 12 weeks, that there was a good positive effect on VO2 max, quality of life, and sleep quality. And we found their fatigue levels also reduced. So today, in today's webinar, we have prominent 4 champions from medical and physical therapy field to discuss the importance of the topic, which is importance of renal physiotherapy in management of CKD, a multidisciplinary approach. These stalwarts will also shed light on advances which are latest to help ignite a healthy discourse for clinicians and academicians in the Indian community for further enhancing their scope of practice and patient care. In the beginning, at the outset, I would like to make a small announcement. All of you kindly keep your connection on mute, except for the speaker. And kindly, all the audience, put your questions in the chat box, which will be taken up in the end. So before wasting any time further, I would like to invite Dr. Manoj Gumbar, who's our first speaker for the day. He has an experience of more than 3,000 kidney transplants. He's a senior consultant, nephrologist, and transplant physician, Apollo Hospitals, Ahmedabad. He's former professor of Indian Kidney Diseases and Research Center, Ahmedabad. He's honorary medical advisor to Gujarat Council of Science on Science and Technology, a nephrologist and hypertension specialist to IIM Ahmedabad, and he has guided more than 40 nephrologists in India. He also produced secondhand a film on organ donation. He's been awarded for the Best Mentor Award in 2018, has published more than 80 articles in various journals. And today, he is going to shed light on sarcopenia in CKD. I would like to invite Dr. Gumbar and would like to thank him from his busy schedule. He is with us today. Thank you, Dr. Gumbar. Kindly.
Yeah, thank you, Dr. Seema. And thank you, Gapio and Dr. Seema and Dr. Hada for giving me an opportunity to share my views on sarcopenia in CKD. I'll discuss the lecture in following details and topics. Now, the most important thing is that patient of CKD presents to physiotherapy department with the chief complaints of weakness. And both, it is the duty of the physiotherapist and nephrologist to determine whether the cause of weakness is of sarcopenic or not. So there are other factors which can cause weakness, and we have to rule all of them, such as anemia, depression, reduced physical activity, heart failure, vitamin D deficiency, hyperparathyroidism, inadequate dialysis, long-term dialysis, drugs. And even before labeling the patient as having sarcopenia, even uremic neuropathy should be ruled out. Now, what is sarcopenia? In sarcopenia, sarc means flesh and penia means loss. In practicality, it is all reduction of muscle mass, strength, and function that defines sarcopenia. Sarcopenia can be divided into two types. One is primary, if it is just age-related and no other factors play any part. In secondary sarcopenia, it is either activity-related, disease-related, or nutritional sarcopenia. Today, I'll be discussing one of the disease-related sarcopenia, that is sarcopenia in CKD. The prevalence in general population is around 10%. And the prevalence of sarcopenia in CKD not on dialysis is around 14%. But as the stage of stage of CKD reaches ESRD and patient starts dialysis, the incidence or prevalence of sarcopenia is around 40% in HD patients. Why are we discussing sarcopenia? Because it leads to poor quality of life overall. There is an increased risk of fractures, falls, hospitalization rates, increased depression, frustration because of the increased dependency on others. Even the cardiovascular complications increase in patients who are sarcopenic, and overall, the morbidity and mortality is more in sarcopenic patients as compared to non-sarcopenic. Now, something about pathophysiology of skeletal muscle in CKD. Both decreased substrate availability and transfer is responsible for muscle weakness. The substrates are deficient because of reduced intake of nutrients, and their delivery to muscles is altered because of the decreased capillarity and increased vascular resistance. Normally, muscle cells use fatty acids and glucose as produce energy. But in case of CKD, there is a deficiency of lipoprotein lipase enzyme, and VLDL receptors are downregulated. Lipoprotein lipase is responsible for releasing fatty acids from triglyceride-rich VLDL and chylomicrons. Now, similarly, glucose is also not available for muscle cells because of insulin resistance. In absence of fatty acids and glucose, protein degradation occurs, and proteins are used as an alternate source of fuel for energy production. Now, something regarding protein degradation in muscles of CKD. First step of degradation of proteins is dismantling of actin myosin, and this occurs because of an enzyme caspase 3. Further degradation of proteins requires packaging with ubiquitin. And this is carried out by an enzyme called muscle-specific E3 ligase. This enzyme is under the regulation of insulin IGF signaling, and insulin IGF signaling is impaired in CKD patients. Even amino acid homeostasis is disturbed. Normally, if amino acids are available, there is an anabolic response and formation of protein. But there is a depressed anabolic response to amino acids in CRF patients, in CKD patients, in whom the amino acid levels are itself low because of the decreased intake. The anabolic and catabolic equilibrium in skeletal muscle is regulated by P13 and mTOR signaling cascade. This cascade is sensitive to insulin and IGF-1. And again, insulin and IGF-1 signaling pathways defective in CKD patients. Etiology of sarcopenia is multifactorial in CKD, and in brief, I will cover one by one. CKD patients have metabolic acidosis, and metabolic acidosis activates ubiquitin proteozyme enzyme system by altering the intracellular signaling and ligation of insulin receptor. There is malnutrition in CKD patients because of the poor intake, food restrictions by the nephrologist, and nutrients loss in CKD during dialysis. Uremia in CKD patients are a state of chronic inflammation, and this chronic inflammation affects insulin and IGF receptor signaling and activates caspase 3. Even angiotensin 2 is elevated, and this too stimulates ubiquitin proteozyme enzyme system. The associated neuropathy in uremia and the electrolyte imbalance to contribute to weakness. Growth hormone and insulin are powerful anabolic hormone, but in CKD, there is a resistance to both of them, insulin and growth hormone, both. Testosterone is a powerful anabolic hormone, but in 60% of the patients with CKD, the levels are too. Patients of CKD have vitamin D deficiency and increased PTH levels in secondary hyperparathyroidism. These two contribute to too much. Patients of CKD are less mobile and less physically inactive. It is a vicious circle. Who initiates what is not known. Muscle loss leads to decreased physical activity, and decreased physical activity leads to increased muscle. But you, physiotherapists, can be the Abhimanyus and dismantle this vicious cycle. There are comorbidities in a patient of CKD, like diabetes, cardiovascular issues, immunosuppressed state, accelerated aging, which all of these do cause sarcopenia or weakness in the patient. Ultimately, the factors which produce muscle degradation overpower the factors which produce muscle regeneration, and a protein catabolic status. Now, regarding diet, anthropometry, bioelectrical impedance, and physical examination are simple ways to diagnose muscle mass, but hydration status affects their measurement. So, they should be done even after dialysis. CT and MR are very good tools to diagnose muscle mass, but they are costly and having high radiation dose. So it is impractical to use CT or MR for diagnosing muscle mass. Dual X-ray absorptiometry is an alternative method with no radiation dose. Muscle strength can be diagnosed by simple tests like hand grip, chair stand test, gait speed test. Short physical performance battery and time to get up and go test can be done to diagnose muscle strength. Now, while I reviewed the literature, it was evident that within 12 weeks of exercise training in the patients of CKD, not on dialysis, the inflammatory stage goes down. There is a significant reduction of interleukin 6 after 12 weeks of resistance training. Even muscle atrophy, which occurs in hemodialysis patients in both type 1 and type 2 fibers. After 6 months, it is possible that 50% of the fibers can be regenerated or increase in sizes there, and even the mean muscle fiber area can increase with exercise training. Even the strength and functional measures improve, even within 12 weeks. In this study, 10 HD patients were subjected to exercise training, and all the measures of muscle strength, that is gait speed, 6-meter walk distance, sit, stand up, set test, were better after 6 weeks. In a study, it was found that peak utilization of oxygen, peak oxygen capacity also increased in patients within 12 weeks from 50 to 70% of them. So I'll suggest that patients of CKD should be supervised while on dialysis. They should be given exercises while on dialysis. No doubt, the exercise models are limited, but this is to increase the compliance dialysis patient. I'll give the take-home messages as supervised exercises are the key to handle multiple issues in CKD. Your motivation, patient's progress records keep the patient compliant. Waitlisted cadaveric patients with exercise training have a better chance of undergoing successful transplant. Early diagnosis and management of sarcopenia will bring the best outcome. And at times, physiotherapists have to become a psychologist, treat CKD patients. To conclude, I'll say CKD patients are more susceptible to sarcopenia and is present in all stages and have important consequences even before the patient is on. Improvement in muscle mass and function in pre-dialysis patients as well as post-transplant, post-dialysis patients is possible and should be encouraged. Resistance training can be used safely to increase strength and functional capacity in stable HD. Thank you. Thanks.
Thank you, Dr. Manoj, for such a wonderful presentation and summarizing the whole thing in such a nutshell, where you've included from pathophysiology, everything, even to what exactly in nutshell we all should look for when we look into the patient. I believe all the participants would resonate the same with me. Thank you so very much for your presentation and for your time.
Thank you, Dr. Seema.
Thanks, sir. Now, without taking any long, I would like to introduce. Thank you so much. So I would like to introduce Dr. Stuti Malhotra, who is from Delhi only, but now settled in UK. And she's band 6 physiotherapist in emergency department and acute medicine for last 1 year. And before that, she was working with older people assessment unit. And she has also had experience for the patients in frailty. She worked there and worked as a renal physiotherapist for a good amount of 2 years. And today I would welcome her to really present to us that what are her experiences during her work time there and what she really has to bring it to us from UK, how a renal physiotherapist will look into a patient on dialysis. Dr. Stuti, to you. Over to you, please.
Yeah, thank you, Dr. Seema, and I extend my gratitude and thanks to Gapio for giving me this wonderful opportunity to talk about renal physiotherapy in patients undergoing dialysis. Is my presentation quite clear?
Your voice and your presentation is fine. Please carry on. Thank you.
Lovely. All right. Okay, so as Dr. Seema introduced me, I had worked with renal physiotherapy in King's College Hospital 2019 until 2021. where I was also working with COVID patients as well. I would like to discuss this topic today into two parts, where I will be briefly talking about the dialysis options and how we need renal physiotherapy going forward. So now renal replacement therapy offers dialysis as a part of the treatment. But why do we need dialysis is because our kidneys stop working properly, and their function where they have to remove the excess water and accumulated waste, they are unable to do. So we have two options, dialysis and transplant. Unfortunately, in India, every patient cannot go for renal transplantation because of unavailability of donor. Second, maybe they can't afford the surgery, or they are not fit enough to undergo the surgery. So the option left is dialysis, which is hemodialysis and peritoneal dialysis. Going forward, hemodialysis is where we use an external filter to filter out the blood, and peritoneal dialysis where we use peritoneal membrane in our abdominal cavity as a filter. I will not go into details of it, but there are pros and cons associated with both dialysis therapy. Unfortunately, in India, peritoneal dialysis has still not reached to an extent it needs to be. There is a study which says by 2019, there are only 8,000 patients all over India who could access peritoneal dialysis because of the high cost of consumables, and the care lies on the patient portfolio to manage their own dialysis. Going forward, there are various side effects of dialysis, and once a patient is on dialysis, the life is changed forever, not only the patient, but also for the family members. There was a study which was done in 2022, which says that 4,807 people with CKD, they were quite questioned and interviewed, and they found that they suffered from not only physical impacts, but psychosocial, psychological, and the life impacts, where you can see fatigue, sleep problems are quite common, then concern about their future, ability to go back to work, and most important, the financial impact of it. So there is a lot of economic, sociological, and psychological burden on the patients. So there is a need for renal rehabilitation to come into action. I was very surprised to learn that the first dialysis happened in India was in 1960. So now we are in 2023. Almost 50 years later, there is a need for renal rehabilitation coming up globally, I would say. But before that, let's go and see what's the global dialysis perspective of India says. So a 2018 estimate put the number of patients on chronic dialysis in India saying 1,75,000, giving prevalence of 129 per million population. That means every year, 210,000 new patients develop kidney failure, and 175,000 roughly patients, they are on maintenance dialysis. Now, as we see, as the choice of modality, hemodialysis remains 94%, and peritoneal dialysis is still 6%. And the funding to access this dialysis is very, very different in Indian scenario. Whereas in UK, mostly it is funded by the government, but that's not the case in Indian population. The economic burden is so high. If one dialysis session is costing around 5,000, so if a patient needs 3 dialysis in a week, which leads to at least 15 to 20,000, that means a 1 lakh of rupees is going to go just for the dialysis of a one family member, which is very, very high financial burden on the family. Going forward, so when we see all these changes, all these things happening for patients at various levels, physical, social, economic, psychological, do we see that our patients suffering from chronic kidney disease too frail to exercise? Probably yes. And the reason is what Dr. Gumbar very well explained about the sarcopenia. It is a vicious cycle, and somewhere and somehow we need to break it. As you can see in this diagram, it's a research conducted in 2022, which says sarcopenia is the center of all these problems. which takes us to loss of muscle mass, loss of muscle strength, which further leads to lack of physical performance, walking ability, standing balance goes away, they tend to fall, exercise capacity is gone, total energy expenditure gets reduced, their dietary intake is reduced, they lose their appetite, and again they become more and more frail. And further it leads to disability, dependency on the family, more hospitalization, leading to poor survival, and later death in the tragic rate. I would say chronic kidney disease, it takes a lot of time for it to show its gradual deterioration. But if, with the help of multidisciplinary team, including physiotherapists, dietitians, counselors, psychologists, nephrologists, if we target each and every problem of these patients, somehow break the cycle, and they should be able to get some quality of life. Now, what is renal rehab? So renal rehab is a long-term comprehensive program which consists exercise therapy, diet, water management, drug therapy, education, psychological, mental support to alleviate physical, mental effects based on kidney disease and dialysis therapy, prolong the life expectancy and improve psychological and occupational circumstances. So rehab means recovering and restoring what is necessary to get on with the living. But this is low priority in most dialysis facilities in India at the moment. And the inclusion of integrated rehab programs for dialysis patients is not routinely offered as a part of patient care. Now we have to understand, before we integrate these programs to our patients going on dialysis, what is physical activity? And is physical activity a renal physiotherapy? So first of all, we need to understand what is a physical function. So physical function is individuals' ability to perform activity required in their daily life, which is determined by many factors, including their physical fitness, sensory function, clinical condition, environment factors, and the behavior factors as well. And this can be improved by physical activity and exercise training. So physical activity is just a bodily movement where there is a contraction of skeletal muscle and there is increase in energy expenditure. But exercise training is a planned structure which a rehab therapist provides to our patients so that there are changes in their outcome measures. Now, when we exercise with chronic kidney disease, we have different areas to exercise. When they are on dialysis, when they are not on dialysis, when they are on kidney transplant, when they are on hemodialysis, or when they are on peritoneal dialysis. So British Medical Council of Nephrology has put in place some practice guidelines for exercise and lifestyle in chronic kidney disease, which I will touch further down. So the recommendations are, the hemodialysis patients should aim for 150 minutes of moderate intensity exercise in a week, or 75 minutes of vigorous activity, or mixture of both. This is as per UK Chief Medical Officer's guideline. And these exercises can be a combination of outside dialysis exercises or exercises done during the dialysis. So, but the Kidney Disease Outcome Quality Initiative practice guidelines for physical activity states that dialysis patients should be counseled and regularly encouraged by nephrology and other dialysis staff to increase their physical level of physical activity. And this is also contributed by a chapter in the book called Dialysis Therapy from the team of in the team I worked with in UK by Dr. Charlene Greenwood. There is a beautiful review which was done to compare and understand the physical activity on patients for dialysis in 2020, where they offered a standard program, including interdialytic cycle or resistance training or walking program, versus alternative approach where they combine many things together. So the effects were very, very different. So with the cycling, the aerobic, the exercises, the outcomes were not very promising, but with resistance training, they saw some modest changes. With walking program, there were improvements in their social and psychological behavior, but when a combined approach was given to these patients, we saw improvement in their social interactions, in their nutrition, and their ability to do their physical tasks better. So the additional symptomatic benefits were a reduction in their depression, decreasing muscle cramps, and reduced fatigue, which was just by a walking program. But our renal physiotherapy team with which I worked at King's College Hospital has done a pedal study. So this is a RCT study which was done on 335 hemodialysis patients. We divided the group into two, the control group and the experimental group. And the primary outcomes were kidney disease quality of life, and secondary outcomes were to measure their physical fitness, blood pressure, aerobic capacity, clinical chemistry, fall safety, and some anthropometric measures. We had some baseline data as well, where we found 62% were male people, 77% patients had hypertension, 39% were diabetic, 8% had a history of cerebrovascular accidents, and 12% had serious cardiac pathologies. But we found that there are significant gaps in the prescription of exercise intervention for patients receiving maintenance hemodialysis. So we need more research to do and see what are the effects. So further down, we did another study, which is the extension of our previous study, where we again divided our group into two, control and the experimental. And we wanted to see that what are the effects of a 6-month intradialytic aerobic exercises on these patients. But unfortunately, our results were not very promising because there were limitations. There were limitations with compliance and adherence because of a lot of hemodynamic instability, low motivation with these patients, and some patients having serious adverse events as well. Now, this was not done in King's College Hospital, but was done in UK, in 3 dialysis centers all across the UK, where their results were promising, and they saw significant decrease in left ventricular mass, significant decrease in T1 mapping and aortic pulse wave velocity, and no increase in ventricular ectopics and arrhythmia. And this was a 6-month program of intradialytic cycling, which reduces left ventricular mass, and it was safe, deliverable, and well tolerated. So we yet don't know. We still need to research and figure out what kind of exercise, what dosage, and form a comprehensive guidelines nationally and internationally. But there are results which are showing us some modest changes in their outcome measures, which are improving their quality of life. They can be some psychological benefits or some physiological benefits in our patient category. And this was a study which was done in the peritoneal dialysis patient group, where we wanted to see what timing is right to do a physical activity, when they are loaded with the fluid or they have done their cycle of 1 PD, or what kind of specific activities should be doing. Should they be working on core? Should they be working on their aerobic capacity? And what symptoms and side effects we have to take into consideration, and some nutrition and fitness advice for them. Going forward, there are some contraindications to exercises, which were a part of our studies, because these patients, they withdrawn themselves out because they had some myocardial infarction within 3 months, unstable angina, acute infection, acute orthopedic condition, uncontrolled hypertension, uncontrolled arrhythmia, or other conditions which arise on the day of dialysis, which is symptomatic hypertension, low blood glucose, cannulation, fistula problems, excess fluid overload. If we are seeing these things in our patients, they should not be exercising with us for some time, and they should be kept in close supervision of their nephrologists and physiotherapists. But that doesn't mean that they will not be able to exercise ever on the dialysis. Their condition needs to be monitored. Potential barriers which are found out in our studies were pre-existing exercise beliefs of patients with hemodialysis unit staff members, which are demotivating factors for exercise. Staff members caring for patients consider them old, too frail, too unwell, uninterested in taking exercise during dialysis. And there was a study when they found that the main barrier is fatigue on the day of exercise, corresponding to 67%, 40% of fatigue, non-hemodialysis day, shortness of breath, and lack of motivation. There are also some non-patient related reasons. They are lack of exercise expertise, lack of facilities, financial incentives, funding for staff, time, and equipment, poor understanding and benefits of exercise therapy, fear of complication, low confidence of junior members who express the need for specialists in nephrology and exercise expertise to support the prescription of intradialytic exercise. So renal rehabilitation at King's College Hospital is a team of specialist renal physiotherapists, including clinical and research team. We offer face-to-face physiotherapy assessments and exercise sessions to our patients. We also participate in transplantation unit, where we offer renal physiotherapy consultation to design and tailor their exercise programs. We also participate in weight management clinic with transplant unit to monitor their weight, and upcoming research projects are still going on at a very, very great level so that we can get those guidelines and inculcate them to our patients and put them across globally. So my take-home message is exercise is very vital component for patients with dialysis. We need to educate our patient population. Side by side, we need to build our clinical expertise and get on with them. This is a topic where we can go endlessly. You can also follow us on www.beingfeelgood.com. This is a virtual platform which I made with my renal rehab team, and this is offering virtual exercise sessions to all our patients globally, because at the COVID, we could not access our patients, they could not access us. It was a good length of time. Their muscle mass could go down, and it was very difficult to get them back to their physical levels. So thank you so much.
Thank you, Dr. Shruti, for such an elaborate talk, supported with the evidence, and in your area in UK, how you formulated. I believe all the attendees would, along with me, will say the same, that it is a lot of insight. Yes, of course, we work on our levels. Most of us do not really document, but this adding to it and giving in-depth information. Thank you so very much.
No problem. Thank you so much. Thank you.
So now I would like to invite our next speaker, Dr. Harda Shah. She's going to speak on advances in physiotherapy management of renal transplant patients. So I would like to introduce Dr. Harda. She is a master's in physiotherapy and a PhD. She's senior lecturer of physiotherapy and PG Guide Transplant Rehabilitation, Gujarat University of Transplant Sciences, Institute of Kidney Disease and Research Center, Institute of Transplant Sciences. And she's in the field for last 22 years with 12 years of rich experience in transplant rehabilitation. Her areas of interest are clinical care, physiotherapy, and transplant rehabilitation. So over to you, Dr. Harda, without taking any long, coming in between you and our audience. Thank you so much. Please. Dr. Harda, we can't hear you. You may need to unmute yourself. Sorry.
Okay. Good evening, one and all. Yes, I hope I am audible now. Thank you very much, Dr. Seema. Yeah. Okay. So, implantation of human organ is now possible because of the availability of a donor pool. A lot of researches in the pharmacology of immunopharmacology and advancement in the surgery. So it is very important to being updated for the number of transplant that is happening day by day. And so today it is a right time to talk about the updates in a role of physiotherapy in kidney transplantation. So, as been explained by beautifully by Dr. Gumbar and Shruti, that these subjects are having complex pathophysiology, and so because of that, they require a special attention in terms of therapeutic intervention that is being termed as a transplantation rehabilitation. So broadly, it can be classified or started in the three temporal classification, like the physiotherapy intervention before transplantation, that may be called prehabilitation, or immediately post-operative transplant physiotherapy, which may last up to 12 months, that is being classified as the early post-transplantation or a late transplantation physiotherapy. So why the pre-rehabilitation is important? So because before transplantation, as explained by our eminent speakers, that there is a deranged physiology, complex pathophysiology, there are years of waiting on dialysis, profound loss of functional capacity, and there is a question whether they will able to sustain the surgical stress. And to improve overall post-transplant outcome, it is very important that all the subjects should be trained beautifully with a combined and multidisciplinary approach, that is pre-transplant rehabilitation. There are certain studies that have shown that the low quadriceps muscle layer thickness is associated with longer length of hospital stay and a burden of financial and societal. And it is being seen that with every 1 centimeter square increase in the cross-sectional area of psoas muscle before transplantation after a therapeutic intervention can improve the mortality ratio up to 14%. That is being with adjusting for the various co-founding factors like age after transplantation, or a dialysis vintage, or whether the type of surgery, or what is the anthropometric or other aspects before transplantation. It has been also been evaluated like via stress echocardiography, that if the patients before transplantation having a good cardiorespiratory reserve, they have a better outcome. So that stress the importance of pre-transplant rehabilitation. I will not be going into detail about that how these people should be rehabilitated, as it has been nicely explained and evaluated by our the speaker. So, like, what will happen after transplantation? So, the transplantation is because all of us know that it is a major surgical event. They are carrying a various cardio-metabolic issues. However, the structure inpatient progressive physiotherapy intervention has proved feasible and safe in hemodynamically stable kidney transplant recipients with normal functioning heart. They are under a close monitoring initially because of the gross fluid and electrolyte imbalance. So as a physiotherapist, we have to have a keen eye in an early post-operative period for any hemodynamic abnormality, any signs of surgical complications, or any signs of delayed graft function or graft failure, any signs of infection, or a better perfusion of implanted graft, and the signs and symptoms like if the patient is recovering well day by day, it is very important. Sometimes we have to modify the exercise schedule or a mode of exercises, or we have to stop for some time. At our institute, we evaluated the feasibility of early post-transplant physiotherapy intervention via direct supervision for initially just after surgery up to discharge. We implemented a progressive aerobic exercises of moderate intensity in form of marching, walking, stepping, cycling, and a gradual progression of a self-weight bearing exercises or free low weight bearing exercises, along with a routine chest physiotherapy and mobilization. After the analysis and comparing with the control group, there was a significant improvement was seen in terms of functional mobility, hand grip strength, and fatigue severity scale. There was a beautiful study described by Matsuoza in Japan. What they did is they started a physiotherapy intervention just 6 days after post-transplant, and then they followed it with a supervised aerobic training. It was being done on 5 days a week for 1 or 2 sessions per day with a moderate intensity and the Borg RP of 13 to 15, either in the form of cycling or treadmill walking. Along with that, they also instructed the subjects to be watchful for the steps via pedometry, and they should progress their steps either for 1 week of 3,000 steps per day and gradually up to 5,000 steps per day, along with the stair climbing. After discharge from the hospital, they were told to maintain the physical activity and for keeping their steps around 8,000 to 10,000. So after intervention, they also found a very good and significant result in terms of functional walking capacity and isometric quadriceps strength. So that proves that the early physiotherapy is safe in a stable kidney graft function patients. And also it does not alter the graft function if it is being monitored and advised appropriately. So in early post-operative periods, if your patient is complaining of bilateral symmetrical leg pain, and especially during night, so one has to be, striking that it may be a drug-induced. That is, a calcineurin inhibitor is a immunosuppressant medications which is been used may hypersensitize the nerve roots, and it is been present in, and it has been seen that it is may be present in 2 to 15% of kidney transplant recipients within 12 months after transplantation. It may be, the patients may be presented like stalk and glowing type of complaint in the hand and legs, and the subjects who are on bortezomib. So it is a polyneuropathy and mostly involves the sensory nerves, but not the motors. So studies have shown that either a modification in the drug doses or alteration of the medications after communication with the nephrologist, along with the physiotherapy like conventional TENS or a range of motion exercises and low intensity aerobic and resisted exercises are helpful. However, there is a low quality evidence for such things. So now let us move to how the physiotherapy can be helpful in late post-transplant intervention after 12 months. So there was a beautiful study done by Zella who mentioned that he periodically examined the data of kidney disease patients. So it has been seen that the level of physical activity and the aerobic capacity does not reach to the normal pre-disease level even after years of transplantation. So this traces that their aerobic capacity does not restored even when the kidney functions are restored. So, and similarly, it has been said that seen like longevity after transplantation, the outcome is better in the subjects who are more active. So that put a stress, like it is a very important phase of a transplantation when the subjects are not active or moderately active. They should be incorporate exercise and activity in their schedule. Even though, however, the normal subjects require physical activity, but I will stress that these subjects are more vulnerable and they require a more good number of exercise counseling to being active. When we discuss about the physical functional capacity, it is multi-phased, and the deterioration of the physical functional capacity is not confined to the physiological factors, but also to the behavioral factors like attitude towards physical activity, fear of activity participation due to fear of graft failure, sedentary behavior or diet behavior, along with disease-specific factors like longer dialysis vintage, presence of metabolic syndrome, abdominal obesity, hypertension, hypercholesterolemia, suboptimal gut function, or a longer dialysis vintage, and the chronic use of immunosuppressant medications and its adverse effect, along with the non-modifiable factors like increasing age and ethnicity and the development of other new comorbidity put in stress, like they are a perfect candidate for transplantation rehabilitation. So before incorporating anyone into a therapeutic intervention, it is a very mandatory task to screen them for any adverse event. So to see for risk versus benefit ratio. And so we have to watchful for any disease-related safety, cardiopulmonary safety, and impact of other comorbidity that is being present and may cause an unfavorable effect during exercise intervention. There are many spectrum of measurement possibilities are there before incorporating them into or to evaluate their basic level of functional fitness, aerobic capacity, or a quality of life. So that range from a laboratory-based, a well-equipped evaluation to a field-based evaluation to a self-reports. However, the purpose and the practicality should be short that what exact need of the patient is required. And it is very important to evaluate to start before intervention and whether the intervention has a good effect on overcome of the deficiency that is being present in their fitness. Many evident researchers have keen interest in renal rehabilitation, and now we have many evidence-based clinical practice guidelines from various countries, like American College of Sports Medicine guideline for kidney disease, Can Restore Steering Committee guideline from Canada, a Japan clinical practice guidelines, KDGO guideline, clinical practice guideline for a kidney disease patient, and a ERA or a UK clinical practice guidelines. However, all these guidelines endorse that all the kidney transplant recipients should be encouraged to being a physical active. They have to maintain a desired healthy weight by incorporating any form of rhythmic aerobic exercises of moderate to vigorous intensity for 3 to 6 days a week with or without a low and moderate intensity of strengthening training along with a breathing exercise and flexibility exercises. So what is the effect of these exercises, whether they are effective in improving the working capacity or aerobic capacity? So even there are 12 months of only aerobic exercises up to a 60 to 80% of heart rate max for 30 minutes, 3 days a week, or a 12-week of endurance training along with the strength training, alternate endurance and strength training exercise for 30 to 60 minutes per session at RP 11 to 30, or a supervised exercise with a stationary cycles, treadmill, or resistance training at RP of 13 and 15 has shown a remarkable improvement in a peak aerobic capacity, as well as the distance walking 6 minutes. Even the exercises have shown that, however, they are all these patients are having a high cardio and metabolic risk. Whether the exercise has a power to reduce the cardiometabolic risk is questionable. So many researchers have evaluated, and as per the study done by Gang Chen, they have shown that the exercise intervention had a mixed impact on cardiovascular disease risk factor. There was an improvement noted in a baroreceptor sensitivity, arterial stiffness, exercise tolerance, and quality of life. However, their study did not able to show any change in hypertension, dyslipidemia, or hyperglycemia. Even a decreased kidney function was not altered, and there was no change in obesity was seen. In contrast to that, the study done in 2020 by Gofferendo Alnetti shown that after 1 year of unsupervised home-based combined aerobic exercises and counter-resistance exercises had a significant echocardiographically proved improvement in myocardial function. That says that even in incorporating a physical activity or supervised exercises or home-based exercises may improve the cardiovascular risk profile, but it will be more helpful if it is been carried out in the longer duration of time. Exercise intervention also improve the strength, as we have seen that this population are having a sarcopenia, dynopenia, they have loss of muscle mass. So whether the exercises are helpful to improve the strength? Yes. Even aerobic training of longer, for 12 months has been proved by Painter et al. Like 12 months of aerobic training has been very effective in improving the quadriceps peak torque. Ress et al. Has observed there is a significant improvement in 1 hour in leg press and leg extension after 12 weeks of exercise group that was mostly a strengthening group, but not in their other control group. In an exert trial, Greenwood et al. Shown that the isometric quadriceps strength was increased in resistant training arm group only, but not in the control or usual care group or aerobic group. So to improve the muscle strength, the dosimetry of the exercise should be a specific goal-oriented approach like strengthening exercise or a powerful aerobic exercises for a longer period of time can improve the functional strength. As we know that because of the chronic effect of immunosuppressions, these patients have a proximal muscle myopathy, which is in contrast with the earlier, they are present with the overall decrease in the muscle mass. Here, because of the adverse effect of immunosuppressions, there is either atrophy of a specifically glycolytic, that is a fast glycolytic type 2 beta fibers myopathies are seen, and which has been presented with difficulty in getting up from the chair or stair climbing. A beautiful study has been explained by Van Hand and Ham et al. In the 2007 that peak workload, aerobic capacity and muscle strength improve significantly either aerobic training group via cycle ergometry at the rate of 50 to 70 peak workload versus a dynamic strength training. That is a high load and a low volume exercise versus a strength endurance training that was a high volume but low load exercises. Even all three aspects had shown that there was a proportion of type 1 beta fibers isoform was decreased and type 2 alpha fibers, that is a fast oxidative fibers increase, whereas the proportion of type 2 beta fibers, they are fast glycolytic fibers, did not show any significant change in muscle biopsy. That shows that how chronically use of immunosuppressants affect their muscle bulk. However, with a designed protocol over a period of time, there are chances of improvement in their functional aspect of difficulties like getting up from the chairs and fatigue. Significant changes in hand grip strength over 6 months of prescribed physical activity or a repeated chest stance performance also shown improvement after 10 weeks of supervised resistance exercise intervention in many studies. At our institute, we just designed, considering their difficulty in attending a supervised sessions and the difficulty of to coming regularly at the centers, we designed and validated a exercise booklet with a colorful illustration of all the exercises that was including the moderate intensity aerobic exercises, strength exercises, pranayama, and warm up and cool down exercises. We evaluated its feasibility by incorporating stable kidney graft function patients with more than 6 months of transplant who had a less than 60% of functional walking capacity. We evaluated 6-minute walk distance, hand grips, chest and capability, and pulmonary functions. And after 12 weeks of intervention, it has been shown that the measure walk in the distance walk after 6 minutes and the functional strength in form of hand grip and the repeated chest strength improved. Even the pulmonary functions also shown a remarkable improvement. Overall adherence was around 60%. That shows that not only the supervised exercise, but a remotely moderated or a illustrated based exercise intervention with a proper guidance and follow-up can be helpful. We endeavored to explore the remedial effect of 6 weeks agility, endurance, and resistance exercise training in our pediatric kidney transplant recipients who were 60 to 80 years of age. We designed a certain more of funny and play type of activity, and we remotely conducted it with a WhatsApp video, and that the real exercise sessions were consisted of more of fun and the moderate intensity aerobic exercise that incorporate the moderate intensity of aerobic exercises and agility exercises and a dancing kind of things that each with a resistance of their self body weight training was incorporated. The kid interested in that much that they were waiting for the next session, and then they were asking that when I will be incorporated into this next session. After the 6 week of intervention, we had proved able to seen the significant change in their 10-hour strength, distance walk, and the quality of life, which was being evaluated by Quindle questionnaire. However, their balance was a little bit good at the baseline, so we were not able to reflect the change or improvement after intervention. The various spectrum of mineral bone disease are present in CKD population. However, after transplantation, because of the chronic use of immunosuppressants and abnormal functioning parathormone, more percentage of cancellous bone is been involved. So there are major, many patients are suffering from osteopenia to osteoporosis. There was a beautiful study has been documented in which they just evaluated the 12 week of resistance exercise training of upper and lower limb body with 2 days per week with a 50% of 1 RM, and which was able to restore or improve their bone mineral density at the femur and the lumbar spine. We also had just tried by a pilot study via a 12-week home-based targeted osteoporosis exercise program at our institute. We screen all the kidney transplant patient for a fracture risk assessment via FRAX tool that has been available via WHO, and a work balance scale, because we planned to supervise this exercise program remotely, and so that they can conduct the exercise program at home without any supervision. And the stable kidney graft function patients who were osteopenic had been incorporated, and we designed a low impact, high velocity body weight bearing exercises along with the balance aerobic training. That was a mixture of this training. And then after 12 weeks, we were able to see the changes in functional mobility and 30 seconds chest stance, quality of life. However, we were unable to see any change in bone mineral density. So we just concluded that our program or a duration was leaking, certainly because it was not supervised, or it may be because of it was a that much, or 12 week is not sufficient to show a change in the bone mineral density in our cohort. We evaluate as the majority of patients are having diabetes at the onset after transplantation, or many of them develop a new onset diabetes. So the volume of patients who are having on anti-diabetic medicines or having a morbidity like hyperglycemia and development of metabolic syndrome is high. So we evaluated a 12-week structured home-based exercise program on glucose metabolism, hemoglobin level, and submaximal cardiorespiratory capacity and balance in our post-transplant diabetic patients. We remotely evaluated and implemented a 6-minute aerobic exercises that was consisted of brisk aerobic exercises in the form of walking or stair climbing, and high volume resistance exercises either using their own body weight or a custom made weights. And along with that, they were also provided a dietitian's reference and follow-up, and they have been followed every weekly up to 12 weeks. So we were able to show a difference in fasting blood sugar, 2 hours postprandial glucose, and HbA1c level. However, the effect size was lower, but there was a significant change was seen in their overall glucose metabolism. They also improved their 6-minute walk distance. However, we were not able to show any difference in their anthropometric measurement or low density lipoprotein factors. As they are carrying a very pro-inflammatory factors, and the transplant induced medicine induced chronic inflammations. The exercises intervention has also shown to reduce the interleukin-6 level, and even they have just shown that a few studies have shown that even a good amount of native immunity, like via T helper cell count or CD4 to CD8 ratio or nature killer cell activity or IgG and IgM level even improved with low level of aerobic exercises. So that stress that the exercises has a significant impact not only on the functional aspect but also for the medicational aspect also. So here we learn that the transplantation itself has a very powerful effect improving, but incorporating the transplantation candidate into the rehabilitation is helpful in reversing the negative spiral of deconditioning and may impact the physiological derangement that has been implanted during a CKD various stages can be reversed at a certain level and following years after transplantation. So there are certain points to ponder, like the principle of exercise training is being applied everywhere, like overload principle, specificity, individuality, and reversibility applied here also. But only we have to set out the goal, that what is the goal we are just planning to, and how the patients, what are the patients need, and how we can overcome these problems via designing a particular effective exercise program. So appropriately measured, tailor-made, problem-specific therapeutic exercise interventions warrant a desired and sustainable outcome in all kidney transplant recipients. Even both supervised as well as home-based training intervention has its all pros and cons, and maybe interact with the attrition or a cost effectiveness of the remotely mediated exercise intervention versus a well supervised exercise interventions. Even in the recent era of artificial intelligence and the recent technology is very promising in improving the aspects of or reaching toward the patients who are not capable of coming out for their health and fitness after a very long period of time. So on the basis of above consideration, it is possible to reduce the cardiovascular risk and to influence the graft survival in all kidney transplantation at any stage. So thank you very much. And it has been
so very much, Dr. Harda, for such an elaborate information regarding each smallest aspect, which we as a physiotherapist should understand, and completely evidence-based. Thank you so very much for a very insightful presentation. Now, I would like to introduce Dr. Paula. She's from Chile. And today she was busy at this moment, she has a presentation going on there. So she was kind enough to share her presentation with us through the YouTube, and I'm going to share that video recorded presentation. I thought our audience will have, like, we've got it from UK, we got it from India, Gujarat, how much we are working on it, and all the respective joinees, of course, at their own centers. Definitely a lot of work is going on. So without taking longer, I would like to introduce Dr. Paula. She is from Chile, and she, as you can see, she's a physiotherapist. She has Masters in Public Health from Sweden. She's a PhD student. And she is also a lecturer and researcher at Physiotherapy Unit, Austral University, Chile. And she is a collaborator in various projects. And she is been practicing renal physiotherapy for last 12 years. So I would like to, I hope, is the screen visible? Is my screen visible?
No, Dr. Seema, no, it's not visible.
Okay, just a moment. I would just share it again. So just 1 minute, please. Is it visible now?
Yeah, Dr. Seema, it's visible.
Member of Chilean Nephrology Society, academic at the Physiotherapy Unit in Universidad Austral de Chile. And
I hope it's audible also.
Inviting me to this virtual
if you can increase the volume, probably it will help.
Management of CKD. Today I will talk about intradialysis exercise programs, new insights. First of all, I will give some few characteristics of people with CKD. They have negative protein balance, and it is characterized by low protein synthesis and high protein degradation. All of this leads to muscle loss, muscle wasting, weakness, low muscle strength, low physical performance, and as you see to your right, it can lead to sarcopenia, frailty, and disability. Another important point to consider is the financial protection. Before you implement intradialysis exercise program, you need to know if there is financial protection for these kind of programs. In each country is obviously different, but the question is, does your country has financial protection for intradialysis programs? In Chile, at least not yet, but we are working on that. And maybe you would like to know that the 25% of our national budget in health is just going to dialysis, drugs, transplant, and vascular access. Now we are going to important issues. How should we evaluate our hemodialysis patients? There is a very recent study, 2023, that recommended test of physical function in CKD because they say there is a wide heterogeneity in physical function test available for clinical and research use. So they categorized these recommendations in two clusters. The category A, it is the short physical performance battery, the sit to stand 5, sit to stand 60, and the time up and go. And they said that these recommendations have good evidence to support their use. By the other hand, we have the category B, and in this category we have gait speed, hand grip strength, incremental shuttle test, 6-minute walk test, sit to stand 10 and 30, and VO2 peak. And they said that this could be used in just certain circumstances. The next question that we have to do is what type of patients do we encounter? We can say that our patients nowadays are obese with a protein energy wasting, low muscle performance, low strength, resistance, and flexibility, low aerobic capacity, low ventilatory capacity, low neuromuscular control, imbalance, and all of this can lead to high levels of disability, low levels of quality of life, frailty, depression, and as you can see in the middle of this figure, it can lead to dysfunction and to functional dependence of these patients. And we can say that these patients also have fatigue, pain, cramps, and insomnia very frequently. So as a summary of this pre-training assessment, we can say that we can measure the aerobic capacity, the strength, the quality of life, the flexibility, clinical parameters like KTV, ventilatory capacity, the lung function, and also the balance. There are two main types of exercises or exercise programs in dialysis patients. So on one side we have the interdialysis programs, and the other side we have the intradialysis exercise program. In the interdialysis exercise program, the person can perform the physical activity or the exercise out of dialysis. So the person may be in their house or in a gym, and then the intradialysis programs are while the person is dialyzing, so it's the intradialysis supervised exercise. And what kind of exercises again? We can think about flexibility exercises, coordination and balance exercises, aerobic, strength training, resistance training, and this strength or resistance training can be in the musculoskeletal and respiratory muscles. So, what considerations must be taken before starting? So the next question is, what already exists in this area from the international to the national level? In a bibliometric analysis that we performed in the 2020, we could see the productivity of the articles about exercise in hemodialysis patients, and as you can see, the productivity has increased a lot, really, from 1986 to 2020. And to your right, you can see the connections between the researchers in this area, and it's very high also. There is a very good connection between these researchers. During the 2021, our reptilian group published recommendations for implementation of physical training guidelines for patients undergoing chronic hemodialysis, so I invite you to read them. There are two international scientific groups. The first one is the European Association of Rehabilitation in Chronic Kidney Disease, led by Dr. Naomi Klein from Sweden, from the south of Sweden. And then it's the Global Renal Exercise, or GREX, working group. And they have a lot of connections in different parts of the world. Now I want to show you two different programs in two different countries also. To your left, you can see the colleague Ana de Alba. She is from Madrid. She works in Fundación Íñigo Álvarez de Toledo. And as you can see, she is working with cycloergometer, but a very simple one. And to your right, you can see the colleague Tove. She is from the nephrology department at Lund University in Sweden. And you can see that she is working with a Motomed. So they use very high technology to treat their patients. And here you can see our local experience in Valdivia Hospital, where you can see combined exercises, flexibility, aerobic capacity, and strength. In those pictures, you can see all of them. Here you can see the experience in Ancud's Hospital, Chile, with the colleague Eduardo Villarreal. And in this picture, you can see a patient working with a threshold. So she's working the ventilatory capacity. The patients really like to work with this device. It is always a pleasure to show this experience in the very north of the country, in Arica. Here you can see the colleagues Patricio and Rodrigo. They trained the patients to run 3 and 5 kilometers. So 5 patients could run, and they trained 6 days a week, intradialysis and interdialysis. So if you have the question that if patients can get to this point, well, here there is this experience to answer that question. Here you can see Las Higueras experience in Talcahuano, Chile, and you can see also our colleague Jocelyn Poehler. She is the first physiotherapist to be hired by a public hospital just to work in intradialysis program. So she's a real renal physiotherapist. What is new in this area? And obviously, technology, virtual reality used in hemodialysis patients. And the first project in the world working with this virtual reality in a multidisciplinary group is the Good Renal Project led by Dr. Eva Segura. But what is virtual reality and what types of virtual reality exist? Virtual reality is a technology defined as the use of interactive simulations created with computer software to present users with opportunities to engage in environments that appear and feel similar to real-world objects and events, where the complexities of the real world are simulated in a controlled environment. And we have two main types of virtual realities. To your left, you can see the non-immersive virtual reality, and to your right, you can see the immersive virtual reality. So, what are the benefits of the VR in rehabilitation? The benefits of VR in rehabilitation are really a lot, but some of them are enjoyment of the therapy or hedonic motivation, reduced perception of pain because of concentration of the patient, and improved movement. And this is because patterns and repetition of movements. A meta-analysis and systematic literature review of virtual reality rehabilitation programs concluded that a virtual reality program in rehabilitation is more effective than a traditional rehabilitation program. So how can we use this VR in hemodialysis patients? In the field of renal rehabilitation, there have been few studies that explore the effects of VR, some of which are improvements in lower extremity and spine strength, increase in muscle mass, and reduction in fatigue. Here you can see an article that shows the effect of virtual reality exercise program on physical fitness, body composition, and fatigue in hemodialysis patients. And in the results, you can see that the exercise group had very good effects if you compare it with the control group. Here you can see our colleague Francisco Martinez, alias Paco. He's part of the Good Renal project in Spain. And he said that the non-immersive virtual reality can motivate more patients to perform exercise due to the perceived enjoyment while exercising, being an advantage regarding the difficulty of getting hemodialysis patients to participate in these kind of programs. And here in these pictures you can see this game called the treasure hunt, where you have to catch the money and to avoid bombs. The Segura and Garcia study in the 2019 suggests that a great concern is the low participation and adherence of dialysis patients in conventional exercise programs, with exercise through VR being an excellent option to avoid this. In this article, they will conclude that this program with VR is safe within the 4 hours of hemodialysis. To your left, you can see part of the Good Renal team, and to your right, you can see a patient in Manises Hospital working with the treasure hunt game. So, what is new? This is the last part of my presentation, and I can tell you that this is part of my doctoral thesis. So it is the intention to use VR in hemodialysis patients. The title of this project is called Virtual Reality Usage Intention in an Intradialysis Exercise Program. This is a predictive analysis through a structural equation model. And this has been performed in 5 cities in Chile. And as you can see, my country is very long. And part of the results, as you can see, are really important because they say that the perceived enjoyment and the perceived utility are factors that are very important for patients. And this is from the perception of patient. And finally, in these pictures, I'm going to show you the people that have motivated me to continue in this beautiful renal area, in this physiotherapy world. Thanks for your kind attention today. I let you my email if you want to make some questions or know about our experience. I'm very sorry that you live today, but I'm participating in the Chilean Nephrology Congress. So you're very welcome if you want to contact me. Have a very good evening, and thanks for inviting me today.
Thanks to Dr. Paula for sharing her insight. And I believe many of you would agree with me that yes, we do work in the field, but they have a lot of presentations since 2019 on virtual reality. We all use virtual reality for many, many things. So now, without taking any long, I would like to introduce Dr. Vimal Telang, who's going to moderate our question answer session. Dr. Vimal Telang is former head of the department, All India Institute of Physical Medicine and Rehabilitation, Mumbai. With a very rich 40 years of experience, she is master's from Mumbai University in 1984, underwent fellowship training in Indonesia in 1994, then bi-regional training in CVR from WHO Sri Lanka in 1998, being a PhD postgraduate teacher, master's in physical therapy, neurophysiotherapy in Maharashtra University of Health Sciences. So without taking much long, and she's IAP, she's a recipient of IAP Oration Award also. She has various publications of international and national journals to her credit. So without taking any long, I would like to request Dr. Vimal Telang to take a few questions. Though we all are very, very late, we are half an hour late from our program. So I believe people want to know a few things. Dr. Vimal, over to you. If you can have your audio and video on and can take one or two questions.
Hello. Hello. Hello.
You're audible.
Yeah. Thank you so much, Seema. At the outset, I would like to congratulate all the speakers, Dr. Manoj Gumbar, for a very enlightening talk on the pathophysiology and, most important, the need of physiotherapists in the rehabilitation team. And I think this will go a long way in view of the pattern of diseases which is evolving. And I congratulate all our physiotherapists, Tuti Malhotra, Dr. Tuti Malhotra, Dr. Harda Shah, and Dr. Paula, for giving a very detailed insight of the outcomes of with physiotherapy, with the outcome measures which have been described at the cellular level, at the clinical level, functional level, as well as at investigative level. So I think that goes a long way in improving the quality of life of our patients. Now, going to the questions, there is one question which has been asking, how do you decide whether a patient is fit for mobilization or exercise during hemodialysis? Hello.
Could you put this question to whom?
I think Dr. Ardash could enlighten us on this.
Yeah, Dr. Gumbar can also tell that.
Yeah.
Hello.
Yes.
Am I audible?
Yes.
Ma'am, can you repeat the question, please?
The question is that how do you decide whether a patient is fit for mobilization or exercise during HD? I think even Dr. Gumbar could throw some light on this.
Should I answer the question?
Yes, both of you. You can answer first.
Yeah. Just in the initial lecture, also I said that obviously the patient is having fatigue or weakness, but we definitely have to rule out other causes of weakness and fatigue before we come to a diagnosis of sarcopenia. Patients of chronic kidney disease usually have cardiovascular issues, and ejection fraction is also low. So you have to get into details. Supposedly, if the hemoglobin is appropriate or not, you check it. Whether the hydration status is proper or not, whether the ejection fraction is good or not, and even the postural drop of blood pressure. Because these patients, especially diabetic patients, have neuropathy. So you should check, each physiotherapist should check the blood pressure, both in supine and standing, to note that there is no autonomic neuropathy in these patients, and then only subject the patient to some form of exercise. This is very essential part of the evaluation before subjecting the patient to physiotherapy.
Thank you so much, sir. Dr. Hardasha, would you like to add?
Yes, definitely. My suggestion is before incorporating in any type of physical activity, we have to evaluate the hemodynamic stability and safety first. Second is what is the level of physical activity, like how much, where exactly the patient stays. Which are the need of the patient? What is the need? Are the basic, baseline capacities like either if it is not possible, then the field-based testing can be done before implementing or mobilizing such patients. And definitely, as I said in my presentations, like what is a goal, or you have to state the goal that what actually we want out of the patient's condition and the patients. And it's not only the physiotherapy that can help, it is a multidisciplinary approach. So we have to communicate with their nutritional need, with their medication alteration. Everything plays a vital role. We need to evaluate that what are their physiological parameters during dialysis also. Sometimes these patients are having some issues like hypertension or hypoglycemia. Sometimes they are complaining of cramps during dialysis. And that may be carried out even completion of the dialysis. So what is the dry weight of the patients on a regular basis who are receiving are on a dialysis? There are electrolyte imbalance may be present, like potassium and the sodium may be altered, or hypomagnesemia, which may reflect in the muscle weakness. So all these factors to be considered while implementing or designing any plan.
Okay, I thank you so much. I had a question. Is that all of you all have shown a great improvement in exercise in all the parameters, doing both the closed chain as well as the open chain exercises, aerobic as well as resistance training. I only wanted to know that primarily in patient with renal dysfunction, is it the type 1 fibers which are affected or type 2 or both equally? You did mention about the type 2B fibers exactly, but primarily is it both fibers or one type of fiber is more affected?
Yeah. There are many studies evaluated or proved via biopsy, like all three types of muscle fibers underwent a disuse atrophy or a fibrosis. But the patients, even on a dialysis, sometimes treated with steroids, or after transplantation, they are on steroid for a certain type of steroids. Not only prednisolone, but other immunosuppressive agents have their unique effect on a muscle histopathology. So, but the studies have shown that basically type 2 beta fiber B fibers that are fast glycolytic fibers, which are responsible for quick power action, they are more involved, and they are pertaining to a girdle, basically not upper girdle, but a lower girdle muscles. Because of they are having more muscle mass, are affected mostly.
Okay.
The whole oxygen transport system is at a halt. So all these factors may lead to other type of fibers, mitochondrial dysfunction and all. So it is not only the type 2 beta fibers may be affected, but even a type 1 fiber, that is a slow oxidative or a fast oxidative fibers, also get affected in these patients. And any type of exercise intervention is helpful to improve their functional mobility. If definitely we want more strength, be specific, then a supervised exercise session will be helpful.
Okay, and one last question has been asked is that what is the experience like when walking with a dialysis patient? How many require assistance, and how important is supervision? I think that is, of course, you have mentioned that, but just your experience with the dialysis patient while you're making him walk. Dr. Stuti could also answer this, if she's...
Yeah. So as far as I understand, the question is how important is supervision during intradialytic exercises, and how walking with dialysis patient is like. So while the patient is on dialysis, be it hemodialysis or peritoneal dialysis, patients are supposed to be in a static position. They are not moving. Because with hemodialysis, they are attached to a machine, and with the peritoneal dialysis, there is also a fluid exchange happening at that time. So there is no exercise where they are walking at that moment, but they can do a static cycling, which is usually attached at the end of their bed, and they are constantly pedaling. Will be my answer to this question. Now there is another question which I can see in the chat boxes. Walking program during dialysis, dialysis exercises are static in nature. Yes, they are exercise and they are static in nature. Now with peritoneal dialysis, there are studies which are telling us that when we prescribe walking to our peritoneal dialysis patients, we need to be careful what time of the day they will be walking. Because when they are doing their peritoneal dialysis, they will of course have that fluid exchange. They will have some fluid back into their abdominal cavity, which will eventually put some strain onto their abdominal muscles, which can further lead to development of hernia. Even if they are walking, the walking needs to be slow and will be gradually progressed. They won't be allowed to do a brisk form of walking straight after their dialysis. And as Dr. Gumbar mentioned, we need to be very careful about their hemodynamic stability before we incorporate any kind of brisk exercise or high intensity or even moderate intensity exercises with them. Clinically, it is seen that we can't push these patients more than what their physical reserves are. We need to see their heart rate, ejection fraction, their hemoglobin status, even the trends in their hemoglobin, because the hemoglobin trend is can be seen quite in downtrending and uptrending as well. So we have to not only see the value for that particular day, we have to at least see for a week. The vitamin D levels are very, very crucial in such patients before we put them on exercises. And as Dr. Harsha mentioned about the loss of bone fiber, we also need to make sure that we are not putting them at a risk of any falls or any exercises which can lead to fragility fractures.
Yeah. One last question, I believe, if we can take with the permission of Dr. Telan. I want to know that, is there a time duration during intradialytic exercises? You people say that the patient should be taken up for exercises in the early hours or later.
The research is saying early 2 hours when they are on dialysis. And clinically as well, we encourage when they start their dialysis, they should be taken up on their exercises. The reasons are, by the end of the dialysis, there is a huge amount of electrolyte exchange which has already happened, and the body takes a bit of time to get stable and back to normal. So if at that point of time we put our body onto an external load of exercising, that can lead to any more fatigue to the patients. That may not cause a physiological harm, but their capacity would be like that. They may not be able to take it. So the best is to put them into exercises in the first 2 hours of their dialysis.
Thank you. That is what we also do. I thought it is important for the listeners to really know that that's way more safer. Thank you.
Yeah. Do we have time? There is one more question. Seema?
The last question, ma'am.
Yeah. They want a clarification of how long you would usually wait post dialysis to commence therapy.
It's a very good question, I would say. As far as my clinical experience is concerned with patients, after they have done their dialysis, we give them at least 12 hours to recuperate from the dialysis session. And we encourage them to do their exercises the following day, not on the same day. Yeah, so yeah, that's what we have been practicing here.
Okay, fine. Thank you so much. Yeah.
I like to add to say that we should, when we begin the hemodialysis, okay, the uremic neuropathy part should be taken into consideration before we commence the exercises, because all the uremic neuropathies, okay, or myopathies will resolve with dialysis. So in the initial, when you start the dialysis, okay, maybe that is not the time when you initiate the dialysis in a patient on CKD, now progressing to ESRD, wait for some sessions. Before that, uremic neuropathy part is taken care of by dialysis.
Yeah. Yeah, it's also said that when patient starts their dialysis, we should not put them on exercises for at least 3 months they are on dialysis. And after those 3 months are done, then we should start doing our assessments, our physical assessments. As Dr. Harsha Harda also mentioned, we need to understand their exercise reserve, what they have. From physiotherapy point of view, we have several outcome measures where we can have our baselines of their balance, their strength, their dynamic strength, their dynamic and static balance, their aerobic capacity. And from there, we should always have a post-intervention outcome measures as well, so that we could know that what we have achieved with our patients with an intervention. So, and all these outcome measures, they help us to clinically reason our intervention, not just to, just to in the sake of doing, but we could clinically reason what we have done and what we have achieved. Yeah.
I would just like to say that doing something is always better than doing nothing, because they have a lot of fear and confusion, like they should do that and they should not do that. So counseling is very, very much important in this population.
Yeah. Yeah. These are one of our barriers in the research as well.
A physiotherapist should become a psychologist in CKD patients. That was my take-home message, actually.
Yeah. Yeah, that's right.
I would intervene in between. Everybody, I believe, who's staying till end is enjoying it so much. We are already overseed the time. And what do you say, Dr. Vimal? I mean,
yes, I think it was a very enlightening session to me, at least, because I've been more in the neuro cases. I think this was a new insight for me, and I'm sure many of the participants also. I think it was very nice. I should congratulate all the speakers again, and Seema for inviting such very eminent speakers for this session.
thank you so very much, ma'am. Now I would like to express my gratitude to all the participants and all our invited guests, speakers, and moderator, and ma'am, you also. And at the same time, I would like to express my gratitude towards Dr. Anupam Sibal, who's the Group Medical Director of Apollo Hospitals and President of GAPIO, present President of GAPIO, for his constant support and vision for enabling this platform, which could help us break the glass ceiling and provide superlative healthcare services. I would like to thank Dr. Gumbar. I know you are in between a conference and you are for us in this room. And thank you so much for sharing your insight. And as Dr. Telan said, it's a good platform where we can really promote that, yes, therapists are a part of multidisciplinary team where they really understand why, what, and how they are going to make a difference in the quality of life of a patient. And in the end, I would like to thank all the members of the audience for becoming a part of this webinar, making it a very lively one, and all the interactions and all the speakers staying till the end to answer their question and answers. I hope you all had a great evening and look forward to seeing you all again in the next GAPIO lecture series. Thanks a ton for your time, for your valuable insight onto such a good topic, which is not really very much practiced. As you rightly said, Dr. Gumbar, that physiotherapists, so many times they work on the psychology of the patient, because we are the people who spend so much of time with the patient. We have a lot of interaction where the patient starts coming up with why or the fears, why he's not undertaking physiotherapy or exercise per se or physical activity seriously, irrespective of understanding, knowing, and being known. So that's very, very true. I believe all of us together can definitely make a difference in these patients' lives. And I thank you all once again and wish you all a wonderful evening. And I would like to definitely mention about Dr. Paula. I believe you all will agree with me, you'll resonate that we practice so much, but for me, working virtual reality into these patients, I had not thought of, to be very honest, till now. But it has given me another insight that where we can really work on the artificial intelligence and the technology and can help these patients, making them maybe much more fun for them. So I thank her. I thank each and every one of you, Dr. Harda, Dr. Stuti from UK, Dr. Gumbar, Dr. Vimal Telang, and Dr. Sushil Jain, who's the advisor, Gafi, at this moment, to be staying till end with us. Thank you, everyone, and wish you a wonderful good evening. Namaste to all.
Thank you.
Very much.